So sorry. My name is IHEANACHO, PhD, RN of the Department of Nursing Sciences, Faculty of Health Sciences and Technology, University of Nigeria, Enugu campus. The title of my presentation is Experiences of Palliative / End of Life Care of People with Life-Limiting Conditions in a tertiary hospital in Enugu, Southeast Nigeria. Lessons from an interpretive phenomenological study. This is presented at the Nursing Congress 2021. Introduction. Caring for dying patients and those with life-limiting conditions requires a great deal of personal commitment, and nurses, who are the commonest form of caregivers, may experience such care in a variety of ways. Nurses that work with patients in palliative phase encounter death, sorrow, emotional situations in their everyday work. Working in situations constantly requiring ethically charged decisions can be experienced as stressful and lonely. Studies show that being with patients facing the threat of mortality from life-limiting conditions may be particularly challenging. The source of stress may stem from letting go and bursting the bubble of hope. According to Leon, letting go reflects releasing patients from perceived norms of the curative culture. This I call the paradox of palliative care. In deciding how to handle patients and relatives, nurses can also experience feelings of insecurity and loneliness. As patients having chronic progressive diseases go through those difficult times and suffering in their lives, it often hides the subtle situation that nurses in palliative end-of-life care have to face, being the ones who spend the most time with patients, dealing with the emotional, psychological, and physical pain that the disease inflicts on them. Earlier studies had focused mainly on patients' situation, with only a handful of studies highlighting the nurses' situation, especially in the Nigerian context where palliative care is in its infancy. A study of the way staff ascribe meaning to end-of-life palliative care is therefore apt, since such studies are virtually non-existent in Nigeria in particular. The statement of problem. Nurses' perceptions and experience of palliative care are crucial to their continued care of clients with life-limiting diseases, especially those in the final stages of life. The study was aimed at exploring the experiences of nurses engaged in palliative end-of-life care using an interpretive phenomenological approach at the University of Nigeria Teaching Hospital, Ituku in Enugu State. The research questions: how do nurses perceive and experience caring for patients living with life-limiting conditions, precisely cancer and HIV, toward the end of life? In this hospital, how does the context of the care, informational, structural, material provision, interpersonal context, care orientation, culture of disclosure, situate these nurses to face the possibility of experiencing psychosocial distress while delivering palliative end-of-life care? The rationale is that studying staff experiences, health, and satisfaction in healthcare is not common in Africa in general and almost non-existent in Nigeria. Little attention is given to staff morale or even the high rates of attrition among healthcare professionals. Since they can always be replaced, many of the services that nurses render are not even visible and may not easily be quantifiable. Palliative care is also regarded as emotionally draining and stressful worldwide, yet no mention is made of staff experiences in the work areas in Nigeria. So, What do these caregivers experience and how do their experiences affect their lives and care of patients? The design of the study is qualitative, using the interpretive phenomenology, specifically Heidegger's hermeneutics. Heidegger's ontology of the being in the world serves as the basis for interpretation of results. Heidegger's semantic phenomenology can be used to provide deeper understanding of the meaning of being a person, as well as what it means to be in the world. It aims to interpret and construct an understanding of the human existence in its everyday world. The goal is hermeneutic, that is to deliver an interpretation of the being in relation to what is being studied. The setting of the study is University of Nigeria Teaching Hospital, Itukozala in Enugu State. So 255 nurses qualify as population for this study, and a sample of 17 participants were selected purposively from the population. The instrument was a qualitative interview guide. Hello? Are you there?
Yeah.
Okay. The instrument was the qualitative interview guide. The lead question says, tell me about your experiences of working in an emotionally tasking area of caring for patients whose conditions are life-limiting or who frequently die, suggesting that death is certain or inevitable. Then probes. There were also field notes. Procedure for data collection. A semi-structured interview was done, and the interviewed data were recorded. All data were collected in the participants' place of work at their convenient time within a 4-month period, except one that took place in the client's home. Ethical consideration approval was obtained. Administrative permission was obtained from the unit heads, the director of administration, and the deputy director of nursing, and then informed consent from participants. Data analysis. Interview were audio recorded, transcribed verbatim, imported into a Vivo10 software for initial coding that yielded 291 initial notes, grouping and regrouping to 17 parent notes were obtained. Then, using a constant comparative approach, the researcher reviewed each subset and parent notes from the transcripts, creating memos and relationships manually and inductively, characterizing beliefs about palliative care in the context of Heidegger's hermeneutic phenomenology. Rigor was ensured by validity, credibility, transferability, and plausibility. Results. An overarching theme was identified which showed that palliative care was provided in an unprepared and contradictory situation and context, leading to experience of tension. This tension among the nurses, this overarching theme seemed to suggest that nurses experienced a tension or disconnect between the understanding and practice of theoretical principles and demands of palliative care and the nurses' experiences of palliative care within a culture of cure, silence, resource constraints, and other contradictions. Overview of the main theme. This statement, or these two statements, captured the idea of most of the participants about the state of palliative care in the hospital, which gave rise to the fact that the overarching theme is that palliative care is provided in a contradictory environment. One participant reported, so in our hospital, palliative care is being given to patients, but it is not like we have arrived or we are meeting up to expectations, but we are trying to get there. Another participant said, no, I don't think we are doing palliative care well here in Nigeria because of so many reasons. One, our skills. I don't think we are competent enough. Then the gadgets, infrastructure to monitor those people to care for them well, the way they are supposed to be. We are not really there, I would say. The type of care we give here in Nigeria, even in this place name of the hospital, I am sorry to say that it's very poor. I don't know the logistics parameters I will mention now, but we have the situation that everybody or so many people do whatever they want and they get away with it. That's one of the participants. So inside each nurse's narrative is embedded an awareness that there should be palliative and end-of-life care, which should be better packaged than what they were than what they had at the moment. Let's try to throw some light on the disconnect. Using field notes, it was observed that palliative care is provided by a small subunit of the oncology unit. The team is made up of a physician and 4 nurses. There's no physical space for palliative care. Patients were managed as outpatients. A few were reached in their homes by nurses. Admission is done in the acute care wards, male and female medical surgical wards, and the oncology ward. They are nursed alongside other patients whose medical condition may not necessarily portend a downward trajectory. That is what I call cure orientation. Palliative team comes in to attend to only those referred to them, which are quite few. Nurses switch between the different care orientations in a given work day. Work situation is quite complex. Nurses may never get to come to full grips in practical terms with the fact that some of their patients are not expected to get better by any medical means. For palliative patients, the concern for cure, improvement, and fight against the disease impacts so much on their palliative care needs. End-of-life disclosure is also compromised in the setting. So the sub-teams emanating, or the teams emanating from the overarching theme include the tension of knowledge and practice, paradox of existence, the tension of disclosure, hopefulness and helplessness, doing palliative duties, experience of stress, and coping with palliative care. So the findings are summarized like this. Though palliative and end-of-life care exists in the setting in principle, its existence was threatened by a gross lack of resources, ranging from physical structure to provision of resources for palliative patient care. Nurses in end-of-life care experienced marginalization and non-recognition. There was no consistent practice of end-of-life discussion between patients and family on one side and healthcare providers on the other side. This confounded the practice of palliative care further, since patient relations have to understand their condition enough to work with staff towards preparation, since patients and their relations have to understand their conditions enough to work with staff towards preparation for end of life and beyond. The actual day-to-day care of patients facing end of life is carried out by ward nurses who have minimal training in palliative care of patients and who are compelled by their work situation to switch attention between palliative patients and non-palliative general medical surgical cases. Based on the foregoing, a disconnect therefore exists between the practice of palliative care as the realities of the setting permits and the practice as taught in principle. Nurses demonstrated a strong dedication born out of personal commitment with their little preparation, but were set up for stressful experience of palliative care through a series of stress sources. Given their personal commitment, nurses were able to maintain a vibrant hope, even in the midst of tough patient situations. However, nurses still coped with the stresses and contradictions they experienced using a variety of coping resources. These coping resources were mostly internally driven, based on personality, resource, and trust in God, which was reportedly firm. None of them reported needing any form of medication to cope. Discussion of findings. Nurses reported distress, mostly associated with frequency of death, the suffering and pain that patients go through in the process of dying, the helplessness they experienced, compounded by the fact that they could not openly communicate with patients, since disclosure is not fully practiced in this setting, as well as acute shortage of resources. The context provides the background, which situates the nurse to render palliative care. It makes room for the care to take place and serves as a backdrop, which figuratively and imaginatively provides a way to describe and understand the background or surrounding context when something else happens. This backdrop, the backdrop of this setting is most captured by the second and third sub-themes. Let's shed light a little on this background using Heidegger's ontological concept, borrowing from this concept of the being in the world to explain that the ontological quest must first move towards the interpretation of the person experiencing the phenomenon that authentically reveals itself. The findings show how factors in the nurse's environment both situate and affect them in carrying out palliative care. Nurses in this setting interact with the physical environment of cure while being required to give palliative care. Then the world of extreme deprivation, where there is lack and non-recognition, then the world of interaction with other professionals, and the world of patients and their relations who make conflicting demands on the nurse, depending on the location. Nurses work within the world of cure, governed by nurses work within the world of cure, govern the physical spaces and their contents. Nurses' routines do not usually focus on palliative themes, except when the palliative patients have serious emergent situations. In this context, nurses also interact with fellow nurses, superiors, colleagues, and subordinates, other professionals too, and these all affect nurses' situation to care for their patients, or nurses' situatedness. So shedding light on the background again, for Heidegger, in order to recognize the other's unique existential experience, the person caring for, which is the professional nurse in this case, must share an authentic, preoccupied solicitude for the cared for, that is the patient. Because the patient exists in, because the person exists in, that is in the world, being in the world, he or she is inescapably affected by his surrounding, which is the environment. Nurses, therefore, based on, from this backdrop, it is seen that in providing palliative care, nurses experience extreme lack and deprivation. In relation to the issue of shortage, a nurse stated that it looks as if they are neglecting them as nurses, and this was in relation to patient care provision. The effect was that nurses reported limited resources and non-provision of materials to work as one of their greatest sources of distress. I interpret that this will be acutely anxiety-provoking for all the staff affected. So in meeting palliative care needs, this excerpt says it resonates across the interview data, things to work with, transportation to visit our patients, money to subsidize their drugs. If only we can change their situation, money for their feeding, transportation to take care of our patients, to take our patients home after their clinic visits, providing food and shelter for patients as it is done in other places, and on and on. Borrowing from Heidegger's being in, I conclude that nurses have been completely submerged in their world and to the extent of possibly losing their sense of self in the world. As for the world, for these nurses, their world has become the world of patients and their needs, the world of patients and their needs. That is their preoccupied solicitude. The culture of silence. I concluded that there is a culture of silence regarding communicating to patients about their prognosis and disease status. Onyeka had earlier stated that in the society where this study was set, speaking to patients about their conditions that portend death in no distant time is almost taboo, because such news are usually rejected by patients' families and even healthcare workers themselves. Hopefulness and helplessness. Hope is a very important concept that is central to life and specifically provides an essential dimension for successfully dealing with illness and preparing for death. In talking about hope in this study, nurses had concern over their patients' recovery. That was the primary concern, and that was where hope came in. They were trying to give patients hope, even in situations that looked hopeless. And then they themselves turn out and become helpless because they know that they cannot validate the hope they are giving. Nurses in this study invoked hope at every point in their care of patients And this resonated across all participants. This reflects their concern for their patients to recover or at least get better. Hope has been identified as an essential resource in the lives of people with cancer, helping them to cope during times of suffering and uncertainty. However, there's helplessness too. Some participants describe the feeling of helplessness they described as they witnessed the pain and suffering of their patients, while they could not do so much to alleviate such sufferings in the context of incurable terminal illness. In such situations, they could only encourage the patients and relations to look to God and hope for the best. Then, placing hope in perspective is another aspect of this. Findings in this study show that some of the nurses tried to better capture the essence of hope in a helpless situation of terminal illness. They described hope in terms of setting short-term goals while recognizing that patients may never get back to full recovery. To place hope in proper perspective, it is important to understand that for palliative and end-of-life care, the focus is on comfort and dignity, no longer on life prolongation. Impact of palliative care. In the course of providing holistic care to patients and family members, the special relationship between patient and the nurse allows for some level of bonding between the patient and the nurse. And when this relationship is threatened by imminent death, it bounces back on the nurse. Again, the strength of the nurse is drained by the thought of impending death. Experience of distress. Nurses frequently reported emotional or psychological stress, but rarely any other type of distress due to demands of their job. Psychological distress can be thought of as maladaptive response to a stressful situation relating to the issue of death and dying. Participant sources of stress were related to the frequency of death. This also has been documented in literature. Stress in palliative care. Contrary to the findings of this present study, the respondents in a study in London did not find their work in palliative care stressful, and they felt equipped to cope with palliative stress. This disparity could be explained by the difference in the level of advancement in healthcare with adequate equipment and training. Where these are available, it is expected that work-related stress will be reduced. But here in Nigeria, nurses are faced with poor staffing, lack of working materials, and even inadequate training. Experiencing coping. On a general note, participants reported that they were coping positively in spite of how distressing their experience and world of caring for palliative oncology and HIV patients have made them. Initially, most of the respondents felt that they would not be able to cope with the pain, suffering, and frequent deaths of patients having incurable illnesses like cancer and HIV infection. However, for every one of them, there has been a recapitulation. A good number had decided that given the opportunity, they would really prefer to specialize in the subspecialties. According to Uren and Graham, the utilization of particular coping mechanisms differs depending on the individual and the context in which the coping is sought. These findings led me to sketch this model I titled the Contradictory Distress Model of Palliative Care Experiences. The representation on the model is based on Heidegger's ontology of being in the world. The being, the central place is the world. The being in the palliative care nurse, you can see her in the middle. The nurse is in the middle, because that is the world of palliative care. The being in the palliative care is the palliative care nurse, and the entire enclosure is the world, which makes up the palliative care context. Like a typical mathematical topology, this world is concerned with the properties of space that are preserved under continuous deformation, such as stretching, crumpling, and bending, but not steering. All arrows go back and forth because every component affects and is affected by every other component. The contextual factors which are deforming, stretching, and crumpling the context are resource constraints, lack care orientation, which is cure, and patient information, which is silence. Lack derives from structural, infrastructural, informational, and interpersonal inadequacies raised by the study participants. These elements of their world exert pressure on the context such that the system is under stress. The boxes represent the sub-themes, which are, of course, tensions, each with at least two sides: However, you remember there is no tearing because the nurses also managed to cope. Conclusion. Nurse participants perceive palliative and end-of-life care as care that relates to end of life. However, this perception was not consistent throughout, since it did not always match with other things they knew about palliative care, nor does their knowledge match their practice of palliative care. Again, the context in which they provided palliative care, which consisted of organizational, structural, infrastructural arrangement, financing, staffing, and interpersonal environment, posed a lot of challenge to palliative care in the setting, and situated care of palliative end-of-life patients within a culture of cure, and seemed to threaten the very existence of palliative care. Nurses' experience of palliative end-of-life care impacted their lives and their care of patients. In spite of the difficulties experienced, nurses were highly motivated to give palliative care, and they gave very selfless service. Nurses reported that they